Welcome back to the deep dive. Today we're jumping into a source stack about under-eye rejuvenation, specifically hyaluronic acid filler.
Right?
It's one of the most requested aesthetic procedures out there, and yet it seems to have one of the highest rates of complications that, people actually complain about.
It's so true. I mean, every aesthetic provider has seen it, and I think
Yeah.
anyone considering it has this fear of that telltale sign of an incorrect procedure.
You mean the puffy, lumpy?
Yeah, the puffy, lumpy, a slightly bluish shadow under the eye that just, looks worse than the hollowness it was supposed to fix.
Exactly. And so we dove into your sources hoping to find, like, the ultimate product recommendation. But what we found was, well, it was far more useful and surprising.
Hmm.
It turns out the key to avoiding all those complications and getting that natural rested look, it has almost nothing to do with the specific brand of filler.
Exactly. Our deep dive reveals that the secret is it's anatomical. It all comes down to injection depth.
Injection depth.
Yeah. The sources just emphasize it again and again. Superficial placement is the single biggest cause of aesthetic failure, no matter how good the filler product is.
So our goal for you today is pretty simple. We're going to give you the technical vocabulary and the anatomical knowledge you need to walk into a consultation and know exactly what to ask.
So you can make sure you're getting the gold standard technique.
Right. We're going straight to those core issues, the visible lumps and that infamous Tyndall effect.
And I think we have to understand the mechanism behind the failure first. The lumps are, well, they're pretty self-explanatory, right? Product sitting where it shouldn't be.
Yeah.
But the Tyndall effect, that's pure physics. And it's pretty unique to hyaluronic acid.
Okay, so let's unpack this. The Tyndall effect is that blue or grayish tint. But if the filler is clear, why does it turn blue under the skin? Is it basically an expensive, subtle bruise caused by physics?
That's actually a great way to put it. It's not a bruise, but it's absolutely a scattering phenomenon.
Yeah.
Hyaluronic acid gel is translucent, but when you place it too close to the surface, light goes through the skin, it hits the gel particles, and it scatters the blue wavelengths back at you.
Ah, I see.
Think of it like looking through a very shallow layer of mist. The light refraction just happens to favor blue.
And the sources really emphasize that this happens because the skin under the eye, the lower eyelid, is just uniquely delicate.
It is. One source called it literally paper thin compared to other facial skin.
Wow.
So when HA filler is put in those dermal or, superficial subdermal layers, it's just sitting too close to the surface. It doesn't have enough tissue to hide that light scattering, and boom, you get the unwanted hue.
And I'm guessing that shallow placement also guarantees those lumps we talked about.
It does.
Yeah.
Because there's no deep fibrous structure to hold the product in place, so it spreads and settles unevenly.
Okay, no, let's be fair to the product itself. We don't want to scare people off completely. HA fillers, they clearly work, right?
Oh, absolutely. We should definitely acknowledge that HA is still the workhorse for tear trough correction.
Yeah.
The sources show consistently high patient satisfaction.
What kind of numbers are we talking?
We're seeing between 80 and 87%, especially for people dealing with more subtle shadowing or just that constantly tired appearance.
Okay.
When HA fails, it's almost always the technique, not the material.
Which brings us to the core technical breakthrough we found in the research.
Hmm.
The solution is a massive anatomical shift to deep injection. We're talking about placing the filler as close as you can get to the periosteum.
The dense tissue layer that covers the bone, yes.
So this is the deep dive solution.
This is it. Periosteal placement is a structural technique. It's not just filling a void, you're providing a foundation. What's so fascinating here is that placing the filler deep either beneath the orbicularis oculi muscle or directly onto the bone creates a stable scaffold.
So you're not trying to smooth out the skin surface. You're actually pushing the entire tissue layer up from the skeleton itself.
Precisely. You're building structural support from the ground up, right on the orbital rim. The technique often involves perpendicular injections, creating these small, column-shaped deposits of filler.
And because it's so deep?
Because the product is protected by muscle and deep fascia, it just completely minimizes the risk of visible irregularities.
Yeah.
And it basically eliminates that Tyndall effect. It's simply too deep for the light scattering to happen.
And here's a metric that should really stand out to you. The deep technique isn't just safer, it's also incredibly efficient.
That efficiency is a huge takeaway. Because you're targeting a very small strategic area right on the bone, the deep placement technique uses substantially less volume.
How much less?
The studies show effective correction typically ranging from only 0.45 to 0.61 milliliters per side. That is a really conservative amount of product for a major structural change.
But wait, doesn't using less product mean it wears off faster? That's
Yeah.
usually the trade-off, isn't it?
That's the normal assumption, but the data proves otherwise for this specific technique. The deep placement results show sustained improvement lasting through 18 months.
18 months?
Yeah. Because the product is stable and it's load-bearing, it degrades slower. One study noted that 90% of patients needed only minor touch-ups after a single week, which suggests just excellent stability and durability. This technique really changes the longevity game.
The sources also hint that the cutting edge might be moving toward more of a mixed approach.
It is. Yeah, the field is recognizing that a combination approach often yields the best outcome, especially for more challenging cases.
So how does that work?
You use the deep periosteal injections for that essential scaffolding, the structural support, but then you pair that with a minor, very careful superficial placement, usually just subdermal, to address any final surface shadows or refinements.
I see. 2 layers.
Exactly. And that two-layer approach consistently achieves superior volume restoration and a reduced Tyndall effect compared to just relying on one or the other alone.
Okay, so we've established that deep structural placement is the gold standard. But how do you, the patient, make sure your injector is actually assessing your individual anatomy for this? That seems like the critical next step.
It is. The required starting point is an anatomical assessment. This is your essential checklist item.
Okay.
If you're considering this procedure, your injector absolutely needs to be measuring the depth of your skin to the bone before they even think about drawing up the product.
And if they skip that?
It's a major red flag, because without that measurement, they are just guessing at the required injection plane and technique.
So why does measuring matter so much? I mean, wouldn't one technique just work for everyone?
Because anatomical variability is massive. I mean,
Yep.
even between your own left and right sides, your specific anatomy has to guide the technique. The sources explain that, measuring the skin to periosteum depth,
Where do they measure that?
typically at the mid-pupillary line and the outer canthus. That measurement is what optimizes the choice of delivery method.
Okay, so tell us what those depths dictate. What are the different techniques we're seeing in the sources?
This is where the technical nuance really comes in. If the depth from skin to periosteum is less than 0.5 centimeters,
So quite shallow.
very shallow, that patient actually responds better to the serial puncture technique. This involves using a fine needle and placing many tiny linear deposits of filler in multiple layers as you withdraw the needle. It takes more passes, but it helps distribute the product smoothly across a very shallow area.
And what about for those with deeper tissue?
If the depth is greater than 0.5 centimeters, they show superior results with the bolus technique.
Bolus.
A bolus is a single, concentrated deposit placed deeply and precisely, often right on the periosteum. It's faster and more structural. The depth dictates which technique will minimize lengths and maximize integration.
That measurable difference it's profound. And it just underscores how customized this has to be. One of the studies said that anatomical difference is why 71% of patients showed a differential response between techniques on opposite sides.
Exact.
Your right eye could be a bolus candidate, and your left eye might need serial puncture.
That's right. And to follow up on the tool question, whether the injector uses a needle or a cannula, the research confirms both delivery systems can get comparable results and satisfaction rates, as long as they successfully reach and target that critical periosteal plane. The tool is really secondary to the depth and the technique that's chosen based on that measurement.
Okay, so we've established the gold standard for subtle and moderate hollows, but the under eye area is complex. What if your problem goes beyond a simple shadow and into, significant hollowing or even pronounced bags? Here's where it gets really interesting, because the required solution shifts dramatically. We need to categorize the full treatment landscape.
Yeah, let's break it down into the 3 most common patient concerns we see in the literature.
Okay, starting with patient type 1. Subtle under-eye hollowness. This is the 30 to 50-year-old patient who generally looks good but is always battling a mildly tired look.
HA fillers, placed deeply, are absolutely first line here. You get those high response rates we talked about.
But is there an upgrade?
There is.
Yeah.
If they want maximum efficacy and reduced Tyndall risk, some sources suggest using a combination, a non-cross-linked collagen filler paired with hyaluronic acid. This combo acts as both a filler and a biostimulator, and it offers superior volume compared to just HA alone.
Okay, moving on to patient type 2. Significant under-eye hollowness. These are the people who look exhausted no matter how much sleep they get. They need serious volume.
Right. High volumes of HA filler, placed deeply, can still achieve good results here. About 63.5% maintain results at 12 months. But at this stage, we really have to consider longer-lasting alternatives.
Like what?
Autologous fat grafting becomes a key option.
Okay, so what's the appeal and what's the trade-off of using your own fat?
The appeal is huge. It's natural, it's your own tissue, and it offers truly long-lasting results. We're talking decades. And crucially, fat grafts release growth factors that actually improve the quality and thickness of the skin around them.
And the trade-off?
The trade-off is the invasiveness. It requires a liposuction procedure to get the fat, and there's definitely longer downtime and more initial swelling than with HA fillers.
And the sources mentioned a really fascinating combination to make that fat grafting even better.
Yes. For optimal fat retention, some studies support combining the fat transplantation with poly-D-L lactic acid, or PDLLA.
PDLLA. That sounds like jargon.
It is, but think of it as highly engineered dissolving sutures. It's a biostimulatory component that encourages your body to produce its own collagen scaffold in the area. That provides a much better environment for the transplanted fat to survive and integrate. It just leads to superior longer-term outcomes.
Okay, finally, we need to talk about patient type 3, pronounced under-eye bags. I mean, patients with actual bulging fat pads.
And this is a critical safety and aesthetic prohibition. If you have true pronounced bags, please do not, under any circumstance, allow filler to be placed into the bags themselves.
Why not?
Because you're just adding volume to an already bulging structure. It'll make the puffiness worse, and you risk the filler migrating. It's just a terrible aesthetic outcome.
So if filler is just completely off the table for true bags, what is the definitive correction?
If the underlying issue is orbital fat prolapse and structural laxity, which is what causes true bags, the definitive correction is surgical. It's a lower blepharoplasty.
Right.
The procedure typically involves repositioning or transposing that bulging fat to fill the hollows beneath it. You're effectively correcting two problems at once. It's the most definitive and long-lasting correction there is.
Is there anything less invasive for bags that still works?
Yes, there are some minimally invasive thermal treatments. The endolift laser, for instance, shows promising short-term results. It gets about 90% improvement in the appearance of bags just by tightening and thickening the skin layers without an incision or long recovery.
So if we connect all this to the bigger picture, it's clear the field has moved way beyond just simple injection. We have these highly specific techniques and alternatives.
Right, they can guarantee safety and efficacy when they're done correctly.
But every deep dive has to address the limitations in the data we have.
And that's a crucial point. While HA fillers are effective and reversible when they're handled correctly, there is a gaping knowledge gap that's really evident across all the research we reviewed.
Okay, so tell us what's missing.
Long-term safety data that's specific to injection depth remains severely limited. We know deep periosteal placement is superior in the short term, say 12 to 18 months, but most studies don't differentiate complication rates by anatomical plane beyond that.
So we don't have the 5 or 10-year data.
We don't. We lack truly standardized protocols comparing the deep versus the superficial technique over those extended periods.
That feels like a huge omission. We know the deep technique is more efficient, it's more durable for at least 18 months, but the comparative data against the shallow technique long-term is just not in the literature. Why is that so hard to study?
Well, it's challenging for a few reasons. Long-term controlled trials are expensive, they're difficult to maintain, especially in an elective cosmetic field where patients might seek touch-ups or other treatments before a study ends.
I see.
But the lack of standardization is the biggest issue. If you don't mandate the precise measurement and technique, which many studies still don't, you can't reliably compare the long-term outcomes of depth.
So it leaves us with strong short-term evidence, but an incomplete understanding of the true long-term risk profile of different injection depths.
Precisely. We know deep is superior now, but we don't have that definitive, decades-long proof of its safety ceiling compared to the older, shallower method.
So what does this all mean for you as you move forward? You are now armed with information that, frankly, most people considering filler just don't have. If you are thinking about filler for hollows, subtle or significant, you have to ask the potential injector this one question. Are you measuring my skin-to-bone depth and committing to periosteal placement using a technique tailored to my specific measurements? This ensures they are following best practices for structural correction and avoiding those lumps and the Tyndall effect.
And that leads us to our final thought for you to explore on your own. Given the proven superiority, the efficiency, and the safety profile of deep periosteal placement shown in all these excellent short-term studies, we have to seriously consider this.
Okay.
Why? If this technique is so clearly better for short-term patient safety and longevity, is the medical community not standardizing and prioritizing the necessary long-term research to definitively prove its decades-long advantage over the older, riskier, superficial methods? It's a compelling question about the pace of innovation versus the demand for definitive safety data.